Welcome back to the deep dive. If you're an emergency department physician working your way through RCEM training, you'll know the ED floor is, well, an unpredictable ecosystem, to say the least.
Certainly is.
And today we are doing a critical deep dive into probably the single most challenging, continuous, and mandatory outcome of your professional development. I'm talking about Specialty Learning Outcome 7, SLO 7.
SLO 7 is so often misunderstood. It's, formally titled Dealing with Complex and Challenging Situations in the Workplace.
Yeah.
But really, for anyone aiming for their CCT, this is where your pure clinical skill gets tested against your moral identity, your leadership, and your resilience under fire.
We've gone through a whole stack of sources on this, covering everything from managing an acutely aggressive patient, navigating these profound ethical gray areas, all the way to just maintaining your own composure when the department is completely overwhelmed. So our mission today is really to define that transition. How do you, the clinician, move from relying on a supervisor to achieving that autonomous, expert leadership that's required for mastery? We're talking entrustment level 3 or 4.
That transition is everything. And it's exactly why SLO 7 is a continuous outcome. It's fundamentally about the complex behaviors you demonstrate, not just what you know.
Okay, so let's start with the baseline then. Intermediate training, let's call it level 2. What's the expectation there?
At level 2, the goal is that you can work effectively with, say, an angry patient or a distressed relative. You can manage difficult team interaction. You're capable.
But there's a but coming.
There's a big but. The crucial caveat is you still rely on supervisor support. If a situation really spirals, you're expected to stabilize things and then get your consultant on the phone, but usually on call from home, ready to give direction.
Right, so the risk ownership is shared.
It's shared. Your supervisor is the safety net, holding that ultimate risk. But that net completely vanishes when you progress to level 3 and 4 mastery.
And that's the paradigm shift we're talking about.
Precisely. This is the big leap in higher training. Mastery means you manage these high-stakes scenarios with, and this is key, no supervisor involvement. You have to show you can own that clinical risk independently.
So this isn't just about resolving a conflict that lasts 5 minutes?
No, not at all. It could be a protracted conflict, maybe involving multiple teams, that unfolds over several shifts or even weeks. And you have to resolve it using well-reasoned, rational, and completely defensible arguments.
So you're the one writing that legally and ethically sound summary, making sure it all sits within the GMC and RCEM frameworks.
Absolutely. The defining feature of mastery here is shifting your professional identity from being let's call it a clinical proceduralist.
Someone just focus on the practical tasks.
Exactly. To becoming a leader who can manage complex systems. If you haven't mastered SLO 7, you haven't really mastered how to lead in the ED.
Okay, let's make that concrete. Imagine a patient refusing life-saving treatment, but their capacity is a bit borderline, it's fluctuating. What does a level 2 trainee do versus the level 4 master?
Okay, so the level 2 trainee, they do a good job. They'd handle the immediate assessment, document it, and then call the consultant for advice on best interests.
Right. Standard practice.
The expert, the level 4 physician, they don't just do the capacity assessment. They're leading the whole multidisciplinary team. They're bringing in mental health, social work, maybe even legal, to build a unified, defensible care plan, all without needing that direct sign-off on every decision.
They own the risk.
Yeah.
And they structure the entire resolution.
That's mastery.
Which brings us perfectly to the internal skills you need for that. You can't lead a complex situation if your own stress response is all over the place. We're talking about non-technical skills or NTS.
Yes, and while they're all vital teamwork, decision-making for SLO 7, we really have to spotlight arousal management.
Arousal management. So the ability to systematically evaluate and manage your own physiological stress response, your fear, and then manage those same responses in the people around you. This is the inner game, isn't it?
It is, and the sources are so clear that when you've failed at this, it's incredibly obvious. The signs of a novice under high cognitive load go way beyond just making a clinical error.
You can see it physically.
You can. We're talking about things like a tremor, tunnel vision, maybe they're freezing up, they can't generate a backup plan, or you can even see the negative self-talk that just undermines their own authority.
And if you can't regulate your own fear, your own physiology, there is no way you can create the calm needed to de-escalate a conflict with someone else. The chaos starts inside you.
That's the link. And training these takes deliberate practice. It's not enough just to know about it. We're talking about structured methods, breathing exercises, grounding
And the
rituals.
5-4-3-2-1 method, that kind of thing?
Exactly. Mental rehearsal of difficult scenarios, positive self-talk. It has to be internalized.
But that feels a bit abstract. How do you actually prove you've internalized it?
Well, the most advanced evidence comes from simulation using biofeedback. You could actually hook trainees up to monitor heart rate variability or even pupillary diameter.
So they get objective proof that their calming techniques are actually working.
They get objective proof. It reinforces the idea that when you walk into a volatile trauma bay or a difficult family meeting, your calm, measured presence is the tool that de-escalates the room for everyone.
So once you've got your inner state sorted, mastery then shifts outwards, right, to managing the dual challenge of conflict.
Yes. On one hand, you have the acutely aggressive patient, and on the other, you have those chronic, nagging interprofessional team conflicts.
Let's tackle patient aggression first. How does the master approach this differently?
It starts with being proactive, not reactive. So using structured risk assessment tools that are specific to the ED, like STAMP.
Staring, tone, anxiety, mumbling, pacing.
Right. Or the ABC framework assessment, behavioral indicators, conversation. The goal is always preventative de-escalation. You're trying to predict the aggression before it even happens.
But sometimes, despite your best efforts, it does become physically dangerous.
And at that point, your focus has to shift immediately to personal safety. That might mean withdrawing or preparing for a physical intervention. But here's the crucial ethical point for mastery.
Okay.
Even during an active restraint, say under a PMVA protocol, staff have an obligation to continue using de-escalation techniques. You are always trying to minimize harm, that's non-maleficence, even while ensuring safety.
Wow. To continue communicating compassionately even during a physical intervention, that's an incredible level of professionalism.
It's the ultimate test of keeping your composure under extreme pressure.
Okay, now for the other side of conflict, team dynamics. That friction between, say, ED doctors and ward staff, or the disagreements over transfers, why is that so common?
What's really fascinating in the literature is that this kind of conflict is almost never just about a personality clash.
It feels like it is and in the moment.
It feels like it, but it's often a symptom of bigger systemic pressures. A crushing workload, poor communication pathways, broken processes.
Yeah.
The conflict is just the canary in the coal mine for an unresolved organizational issue.
So the goal for the SLO7 expert isn't to win the argument.
No. It's to find the system failure that's fueling the argument in the first place. For level 4 mastery, that physician sees an acute conflict as an opportunity for organizational growth.
So you don't just resolve the dispute over an unclear admission policy and walk away.
Exactly. You demonstrate mastery by then leading a measurable quality improvement project. Maybe you develop a new handover tool or update the guideline to fix the root cause. You're directly linking your SLO7 leadership to patient safety, which is domain 6.
You're not just patching the problem, you are reforming the system.
That's the shift.
Which moves us neatly into the gray areas. SLO7 demands really sensitive handling of ethical dilemmas. End-of-life care, resource allocation when the system is failing.
And for that, you need a structured approach, not just gut feeling. For acute bedside ethical analysis, the go-to is the established 4-principle approach.
Autonomy, beneficence, non-maleficence, and justice.
Correct. Autonomy is huge in the ED capacity assessments, respecting a patient's refusal of care. Beneficence is about doing good, and non-maleficence is avoiding harm, which includes avoiding futile care.
And justice. That one feels like the hardest, especially when you're crowded. It's about fairness in how you distribute resources.
It is. It's incredibly difficult.
So let's take a real-world scenario. The department is critically crowded. Triage flags 2 patients. One is an elderly patient with end-stage COPD, needs intubating now but probably won't be successfully extubated. The other is a young, fit patient with severe asthma who needs the last critical care bed. How does justice apply there?
That scenario is brutal. It forces you to balance that ethical tension between greatest need versus greatest benefit. Mastery is about being able to articulate a defensible rationale for your decision.
So you might lean on beneficence, maximizing the chance of survival for the asthma patient.
You might. And you'd have to acknowledge the inherent conflict with justice in denying potentially futile care to the elderly patient. It's about showing rational, objective decision-making under that kind of intense pressure.
What about the highest stakes dilemma? Navigating professional misconduct. You suspect a colleague might be impaired or has acted unethically.
That creates a huge risk of moral injury. Mastery there means you have to show a very clear, rational prioritization of patient safety over any sense of collegial loyalty. You apply the GMC guidance rigorously, and then you have to critically reflect on why that institutional escalation was the necessary professional action.
Right. And to handle any of these high-stakes conversations, breaking bad news, getting consent, we know that structure is absolutely vital.
It's essential. Structure creates psychological safety for everyone. For those difficult conversations, we use models like the Spikes QA framework.
Can you just quickly break down the purpose of that structure? It's not just a checklist, is it?
No, not at all. Spikes make sure you establish the setting and understand the patient's perception before you give them any knowledge. The QID part is about managing the complexity. Answer their questions, checking the information was understood, and critically, the documentation to protect everyone.
And when emotions are running high, there's the NRC acronym.
Yes, NRC helps you process emotions rather than just react to them. You name the emotion, understand its driver, respect their view, offer support, and explore their story. These frameworks turn a chaotic conversation into a structured, competent one.
So all of this high-level competence has to be rigorously documented in your portfolio for ARCP. How do you build compelling evidence for SLO7?
The evidence has to shout autonomous, system-level leadership. So first, you need a minimum of 3 extended supervised learning episodes, or ESLEs, every year.
Why 3 ESLEs specifically? What should they capture?
They need to capture those big, complex leadership moments. Mediating that difficult transfer with another specialty, commanding the department during a crowding crisis, leading that high-stakes family meeting. The ESLE isn't just about a clinical task. It's about you managing the whole complex situation and the system change that came after.
And your multi-source feedback, the MSF, also needs to be strategic.
Absolutely. Your annual MSS has to prove you can work effectively with people outside the ED. So you need to actively seek out detailed feedback from ward sisters, mental health liaison staff, maybe even operational managers. The panel needs to see objective proof that your professionalism extends beyond your own team.
Okay, let's talk about the real hallmark of mastery. Critical reflection. Just describing what happened isn't enough, is it?
Not even close. High-quality reflection have to use a structured model. The 3-stage process is key. What? Describe the incident and your reactions. So what? This is the deep analysis. Compare your actions to theory, identify the core problems, evaluate the ethics, and crucially, now what?
Right. What are you going to do differently next time?
Exactly. Articulating how this learning will lead to a concrete change in your future behavior or even institutional practice. If there's no now what, the learning is incomplete.
And simulation and debriefing must be a goldmine for this kind of evidence.
A gold mine. Documenting your participation in a structured debrief, especially using methods like advocacy inquiry or tools like SDOP5, is superb evidence. They're designed to get to a shared understanding of what really happened.
And what does that shared understanding look like? I've heard the term NAFs used.
Yes, it means you're identifying and examining the frames that drove people's decisions. NAFs stands for knowledge, assumptions, and feelings. It helps the team understand the context. Why did someone assume a bed was free? What feelings were driving that rushed handover?
Ah, so you're revealing those frames. You shift the focus from blaming an individual to finding the system breakdown.
And that is high-level SLO7 evidence right there.
So we've really dissected the scaffolding for expert leadership. SLO7 mastery is that successful, sustained integration of professionalism, ethics, systems leadership, and crisis management. It allows you to manage chaos on your own.
And it demands what's called adaptive expertise. This means taking established management principles, maybe even ideas from industrial engineering like Lean or Six Sigma, and actually applying them in the novel, high-stress setting of managing patient flow during a major incident.
And to do that, you need macro situational awareness. You're not just looking at your patient in Rhesus Bay 1. You're monitoring the entire hospital's capacity, anticipating where the next failure point will be.
And the highest level of confidence in SLO7 really is demonstrated through mentorship. By modeling this professional conduct, you create a departmental culture that values reflection and psychological safety. You build resilience into the team itself.
So here's the final thought we want to leave you with. You, who are demonstrating this ultimate level of leadership, given that most of these challenging situations are rooted in organizational failures, how can you, the new leader demonstrating SLO7 mastery, ensure that every complex incident you resolve gets transformed into a system-level QI project?
So that it permanently changes how the department works, rather than just fixing one person-to-person conflict.
The ultimate goal is moving beyond just resolving a challenge
To engineering a safer, more resilient system. one that's designed to accept how we humans actually think and operate under stress.
That's it for this deep dive. We hope this framework helps you evidence and achieve your next level of entrustment. Until next time, keep digging.